Well, good afternoon, everyone, and welcome. I am, as Deb suggested, Mary Naylor, co-director for the Interdisciplinary Nursing Quality Research Initiative, or INQRI program. I have the great fortune to collaborate with Mark Pauley in the leadership of this program. In fact, on this next slide, you'll see a picture of Mark, Lori Melikar, who is the senior program officer, and I think a younger version of me. One of the people not included, and we'll have to change this, Heather, is Heather Kelly, whom all of you have heard, but we together have been a part of the design and implementation of the INQRI program. And I'd like to welcome you to the third webinar in our series on dissemination and implementation of evidence-based practices. INQRI is a program sponsored by the Robert Wood Johnson Foundation, and we are so grateful to our colleagues at the Foundation for all the support that they've provided to the program and to our grantees over a number of years. This next slide is pretty interesting. It's a slide that shows some of our initial brainstorming ideas for the program. This artistic rendering was a product of actually one of our original strategic sessions held during our first annual meeting in 2006. With the Foundation's support, we've tried to figure out how to generate and disseminate and translate knowledge that demonstrate nursing's contributions to the quality of health care. And while we were waiting for all of you to join us, Heather reminded me when this was first developed that a cab driver taking one of our grantees or stakeholders coming to this meeting said, well, what do you need a program to show and demonstrate what nurses do and how important they are to health quality? Well, we, of course, believe what that cab driver said, but felt it was important to produce the rigorous evidence to support that claim. During this webinar series, we have the great opportunity to turn INQRI's focus on part of our mission, very important part, on dissemination and translation. And the findings from 6 projects that were selected in 2010 are being presented via this series. Here on this slide, you have a sense of what is to come. Today we're going to be talking, and we're tremendously excited to hear about the creation of a nurse manager development program to increase patient safety. But that's just also to whet your appetite for 3 webinars yet to come, and the schedule is there on the slide. You can register for all of these sessions, and we would strongly encourage you to do so on the www.inqri.org site, where you can also see the previous sessions. Now, one of the things that I think we've benefited most from in the development of this program has been our connection with a group of national advisories. These are individuals that are made up of people, experts really, from multiple disciplines, multiple fields. And as you can see in this diagram, they have contributed in many, many ways, from conceptualization of the program through its implementation and now evaluation. They've advised, they've reviewed proposals, they've provided direct input to grantees who've been funded to think about how they could even get to a better outcome with their work. So in so many ways, they've been central to our success. Joining us today is one of our distinguished National Advisory Committee members. In just a moment, Jose Pagan will introduce you to Linda Flynn, Joel Cantor, and their work on the program you'll hear about. But in the meantime, it's my privilege to tell you a little bit about Jose. He's professor and chair of the Department of Health Management and Policy in the School of Public Health at the University of North Texas Health Science Center at Fort Worth. He's also an adjunct senior fellow of the Leonard Davis Institute of Health Economics at my home institution and Mark's Penn. He received his PhD in economics from the University of New Mexico. His research focuses on the effects of uninsurance on healthcare access and quality in local markets. He was a consultant on community uninsurance and healthcare quality for the 2009 report by the Institute of Medicine. He was a Fulbright Scholar in Mexico, a Robert Wood Johnson Health and Society Scholar at the University of Pennsylvania, and the 2007 recipient of the Investigator Award in Health Policy Research from the Robert Wood Johnson Foundation. In addition to all of the work that he's done to support INQRI, and it's been a ton, he also serves as member of the National Advisory Committee for RWJS Health and Society Scholars Program. Jose has been an incredibly active contributor and member of our National Advisory Committee since the beginning, and I want to publicly thank him for his amazing support and for leading our session today. So, Jose, with that, I'm going to turn it over to you.
Thank you, Mary, and welcome everyone to the INQRI webinar series, Translating Research into Practice. Leadership skills are certainly important in creating a work environment that promotes patient safety, and Drs. Linda Flynn and Joel Cantor built upon their INQRI research to design an intervention to increase patient safety by enhancing the leadership and team-building skills of nurse managers. Dr. Linda Flynn, she served as the Associate Dean of Graduate Education at Rutgers College of Nursing at the time this study was conducted, and she now serves as a professor, director of the PhD program, and interim chair of the Division of Adult and Senior Health in the College of Nursing at the University of Colorado. Due to the policy implications of her work, she's a past recipient of the New Jersey Governor's Merit Award for Excellence in Research and was inducted as a fellow in the American Academy of Nursing in 2009, where she serves as a member of the expert panel on quality healthcare. And emphasizing the need for nursing researchers to translate findings into practice and policy, she teamed with Dr. Gary Dixon to publish a book in 2008 called Nursing Policy Research, Turning Evidence-Based Research into Health Policy. And Dr. Joel Cantor is the director of the Center for State Health Policy and professor of public policy at Rutgers University. His current research focuses on healthcare coverage and delivery systems reforms. He's currently working with New Jersey state officials to inform the development of the state's response to the Patient Protection and Affordable Care Act. And he's also leading a team working with the New Jersey Medicaid program to implement and evaluate the New Jersey Medicaid ACO demonstration project. Last year, Dr. Cantor was awarded a Healthcare Innovation Award by CMS to support a large-scale adaptation in 4 cities around the country of the High Utilizer Care Management Initiative. Again, welcome to everyone, and now I turn this to Linda and Joel.
Okay, thank you so much, Dr. Pagan. I want to say welcome to all the participants and happy Valentine's Day to everyone. We are all familiar by now with the IOM report, The Future of Nursing. And one of the main recommendations of that report is to expand opportunities for nurses to lead. But we need to ask ourselves, how have we done as a profession in preparing nurses to lead? And how have we done specifically in preparing frontline nurse managers to not only be managers, but to be transformative leaders? And that's really what this project was directed towards. We know that competent nurse managers enhance patient safety for some prior work that was done. But we also know that few nurse managers receive any real management training when they take that first frontline manager position. We seem to have a historical perspective that good nurses make good managers, and yet we know that those are very different skill sets. To make this point, in one of my prior studies, also funded by the Robert Wood Johnson Foundation, in my sample of over 22,000 New Jersey RNs was approximately 10,000 staff nurses across the state in all types of settings. And of those 10,000 staff nurses, or close to it, 43% reported that their nurse manager was not a competent manager. And so that just goes to show you some of the deficits that we experience, some of the work that we have not done in preparing nurses to accept and to excel in leadership and management positions. And I just want to add that a very comparable number, about 40% of those staff nurses also reported that they never were thanked by their manager when they did a good job. They were never recognized for a job well done. And that's important to remember because we will revisit that fact as we talk about this management development program. So, theoretically, absolutely, frontline managers, a competent, supportive frontline manager is one of the 5 pillars of what we consider to be a supportive work environment, according to Aiken's Nursing Organization and Outcomes model. And according to that model, this supportive work environment enhances nursing processes of care, enhances the quality of care, and ultimately enhances and supports positive patient outcomes. So theoretically, the frontline nurse manager is an important part of creating a supportive work environment. The question is, how do we get there? How do we create and develop supportive and competent frontline managers? So I'm happy to say that this translation project was indeed funded by the Robert Wood Johnson Foundation in the INQRI program, and I just, on behalf of our team, want to express our sincere gratitude and thank you to the Foundation for their support of this work. So our team, joining us today is Dr. Joel Cantor. He and I were dual principal investigators on this project. Also a member of our team was the noted journalist and patient safety advocate, Suzanne Gordon. One of the principles of translation research is to have a highly visible champion that the end users recognize and would trust, and Suzanne filled that role for us in the translation of this program. Also on our team was Dr. Kate McFall, who's an expert in occupational health, particularly occupational health of nurses within hospitals. Our qualitative researchers were Dr. Terry Lindgren and Dr. Jerry Dixon. Our quantitative researchers were Dr. Dalia and Dr. Lang. And Allison Creary was our project manager and all-around help in every situation. So many thanks to Allison. So what did we develop? Well, we call this the Nurse Manager in Action Program, or NMAP. And we developed it to be a 5 full-day frontline manager workshops. They were held for a full day once a month for 5 months. And that was very deliberate because this was developed to be very interactive. The managers who participated had homework. They were to go back to their hospitals, implement the skills that they had learned during that workshop, and then come back the following month and report on that and discuss what worked, what didn't work, what we could do to help them enhance those skills. So it was very interactive, and they had their own set of assignments after each workshop. The NMAP program was based on the principles of crew resource management. And so you might ask yourself, what is that? Well, as you may know, that was a program developed by the airline industry to enhance safety during flights. And the core principles of crew resource management are several. The first is that every team member, regardless of rank, is engaged in keeping passengers, or in this case patients, safe, and that their voice is heard. It's heard above any hierarchical structure that might be present. A second principle is that the leader of the group, be it the pilot or the nurse manager, has transformational leadership skills. Thirdly, that there is excellent communication among team members and a management of conflict that enhances and allows that good communication. And then fourthly, something that's called situational awareness, and that's all members of the team need to be constantly alert to possible threats to safety and then take action to address those threats in a very proactive way. So these principles were embedded in our Frontline Manager Development Program. And so the 5 full-day workshops address such topical outlines as what are the principles of crew resource management and why is that important to nurse managers, team building, the skills required for transformational leadership, conflict management skills, team communication building skills, and situational awareness that we presented as enhancing patient safety. Let me say that also the last session was a train the trainer session. Part of the dissemination strategy for this program was for each of the nurse manager participants to be provided with a curriculum, a workbook, and to go back to their setting and become the trainer themselves, and to help increase the management skills of their fellow nurse managers back in their setting. So in the end, the participants were also key dissemination members. So who were these participants? Well, 17 New Jersey acute care hospitals for a total of 56 medical surgical units. Of those 56 units, approximately 34, I believe, were intervention units, and the sessions were attended by 36 frontline managers from those units, and approximately 20 others were selected as control units in our design. Also, on each of the units, all 56, whether they be intervention or control units, we conducted RN surveys of the staff nurses on the units, with measures embedded in the survey that would measure the nursing practice environment, the nurses' perception of conflict management on their unit, their perceptions of teamwork on their unit, their perceptions of their managers' team building skills, and other key measures in this study. So a picture is sometimes worth 1,000 words, and I just want to share with you some pictures of our training sessions. We pulled together a faculty of experts from around the country. This happens to be Karen Kowalski, who ironically is actually from Colorado, and she is considered a national expert on transformational leadership, and she developed and delivered that part of the content. Again, these were developed to be highly interactive. There were all kinds of role modeling and breakout sessions during these workshops, and it was really, I think the participants had a very good time. This is Bridget Regan. She is from Berkeley, and she is an expert in conflict management. Her background as an attorney and ombudsman, and developed a program of research and a theory on conflict management. And you can see her here talking with the participants. Here's a little role-playing exercise between the journalist Suzanne Gordon and Bridget Regan with respect to conflict management. So again, there was a lot of role-playing, scripting, and everyone was engaged in these exercises. Part of the principles of translation science, in addition to having a champion, is to have an intervention, be it a frontline manager development program or any kind of intervention that is easily recognizable and appears to be packaged, and that is branded, and that also includes cues to action. So here are some ways in which we packaged and branded and provided cues to action for the Nurse Manager Training Program, or what we are calling NMAP. You can see there that we developed a nice little logo. It was on all of our materials. Each participant received 2 workbooks or 2 manuals. One was for their own development and their own skill development, and the other was their Train the Trainer manual. You can see the log book there. That was part of their homework projects and developing their skills and recording and engaging in reflective practice with respect how they were doing in achieving those competencies. You can see the coffee mugs. You can see the tote bag. And that little badge there is indeed a holder for, say, a facility badge, but embedded in it are the top 10 take-home points from the entire management development program. So this was all part and parcel of our branding and our cueing and our packaging of the intervention. As I said, everyone had assignments. They also had a host of resources that we provided. For example, they had assignments in a book on emotional intelligence. They had to assess their own level of EI and a plan for increasing that. They received copies of Suzanne's book about nurse advocacy called When Chicken Soup Isn't Enough. They received copies of a textbook on transformational leadership development, a copy of a play, Bedside Manners, that very nicely illustrates good communication between team members as well as poor communication between team members. It's just a very artistic way of making that point and for initiating discussion. So there were a host of resources that our manager participants were provided with. This was a study, a translation study, so we did indeed have an evaluation design. We used mixed methods. We started with qualitative interviews with 10 of the participating managers. We interviewed them early in the workshop and then about 6 months after the workshop series. And the qualitative interviews focused on their perceptions of their skill development, what they learned, how they put it into practice, and how they did or did not believe, or how they did or did not perceive that their management skills affected patient safety on their unit. So we have some interesting findings with respect to that. And then we also conducted the RN surveys on all 56 units pre-workshop and then about 3 or 4 months after the workshop. And then lastly, we collected patient outcome data on all 56 units, the control units and the intervention units, for a full year, spanning a time before the intervention or the nurse management program started, during the nurse management program, and then several months after the nurse management program. And those patient outcomes focused on patient falls per 1,000 patient days on each of these 56 units, and also documented medication errors on each of those 56 units. So let me share with you our post-workshop qualitative findings, and I will try to briefly go through these, but I think that they provide a lot of rich description of what the participants experienced. And our qualitative researchers, in addition to identifying the themes, categorize these reoccurring themes into process factors, outputs of the program, and then outcomes of the program as described by the participants. So I'll briefly share some of that with you, and I'll start with this first part over here, the process factors. The reoccurring themes were great strides in enhancing communication back on their unit, demonstrating how they valued staff, and the beginning of engaging staff in patient safety efforts. So I just want to share with you a couple of their direct quotes. One nurse manager reported, "The communication skills that we were able to learn have really been probably the most useful tool. You know, how to have those hard conversations." Another nurse manager said, "A lot of times we look at our staff and dictate to them, this is what you got to do, but we don't fully explain it well, and we don't make sure everybody is on board with it or make sure that they have all the right resources. So I think this program has really helped me to look at each one of my staff members as an integral part of the process." And as you remember, that is a key foundation of crew resource management. So we were thrilled that this was a theme in the qualitative findings. With respect to valuing the staff, and remember, as I reported earlier, 40% of 10,000 staff nurses said that they never received a thank you. Well, we certainly drove that point home in this manager development program. 90% of our interviews with the nurse managers reflected these kinds of descriptions. And this nurse manager said, "I integrated the thank you. Showing your gratitude to staff. I have really been focused so that the staff feel appreciated. Showing public gratitude, I have integrated that." Another manager said, one of the things I do now, at least more consistently than before, is to actually praise people and thank them for a job well done, not only in public, but I'll also send them little notes and cards, or I'll post something. Now, for those of us with a management background, we understand this is Management 101. This is the low-hanging fruit. But again, remember how important that is and how evidence supports that this isn't always done. So this was an important take-home point of this manager development program. Valuing staff and active listening. One manager reported the listening skills with the staff, because you get so busy when the staff come into your office. I try to multitask, but I have learned to stop and focus my attention to what that person is saying and try to actually listen to what they're trying to communicate to me. And again, that was a major take-home point of this program, that when somebody walks into your office, you don't stare at your computer, you don't play with your cell phone text messages, you stop what you're doing, you look at them in the eye, and you listen to what they have to say, regardless of hierarchy, regardless of rank, regardless of position, a key principle of crew resource management. Being present. As one manager said, is if the staff knows that there is somebody they can go to, even for reporting errors, we build a sense of accountability by being present, by rounding on them, by talking with them, by getting to know them. And again, a key principle of transformational leadership. They also talked about other ways which they engage the staff by initiating huddles if they weren't already doing that, by the use of bulletin boards, etc. But staff engagement was a key component of their development program, and it also was frequently referred to in the interviews. So with the core of this enhanced communication, they then talked about building on those skills to manage conflict, promote teamwork, and strengthen relationships with their staff. With respect to managing conflict, one manager said, I am listening and trying to hear exactly what they are trying to tell me. Then I let them help to resolve the issue. That's usually the problem. So we're working on resolving that, and I just listen at first and don't jump to conclusions. I've learned that this helps them to problem solve. And that was one of the key conflict management principles that we taught them. Don't try to be the superhero to rush in and solve all problems. Listen and then facilitate the staff in resolving their own conflicts. That they have to own the problem and own the solution. So it looks like they, as a reoccurring theme in the qualitative interviews, that they did learn that point. Teamwork, as one manager said, we now try to help each other, offer help. Before, everyone just seemed to be working by themselves. So I think we've seen lately some team building. One person is done for the day, so others offer to help another person. And again, that was a key component of the workshops. Building on those competencies, they then talked about moving forward with encouraging staff in the decision-making process and encouraging patient safety innovation. And we'll just see what they had to say about that. As one manager said in the interviews, I learned in the workshops how communication is so big. Now I'm giving them a lot more information, referring to their staff. It's going to help them make decisions on the unit, which really has worked. In the past, they didn't really have as much input. So now with everything I've learned and giving them more information and asking all the right questions, I'm feeling that they are getting more involved. And obviously, we were thrilled that that was a reoccurring theme. With respect to innovations, one manager said, we now put our heads together and we talk about things. It was different ideas that people shared. So the staff had a program now where they hang a sign over the patient's bed, and that way it would tell you about their diet, their activity, and increase patient safety. That was a good idea that we shared, and they implemented. Another nurse manager reported back to us, right now we're looking at locks for medications. Right now we have keys, but the keys get misplaced, And so one of our staff had recommended that we get these coded keys. So we looked at a vendor, we looked at costs, and now we're going to install them within the next few months. So again, successes in actually engaging staff in innovation and increased safety. So what did these managers describe that they thought were some outcomes of all of this? Well, as one manager said, I think with the coaching, I'm able to see our fall rates that have been decreasing because the staff are now taking ownership of the unit and are rounding more frequently. They are in the rooms. They are decluttering rooms without me having to point things out to them. They are actually going into the room and taking care of the different tasks that need to be done. Again, to us, this seems like basic teamwork, basic patient safety, but for many of these managers, the staff engagement was an improvement. It was something that had not been going on before. I think that this is probably a good time to point out that although qualitatively the managers talked about how they thought they saw reductions in falls on their units or decreases in medication errors, quantitatively, unfortunately, we did not find that. There was no significant difference several months after the program implementation was completed with respect to these patient outcomes than there was before the program. And there could be many reasons for that. One could be simply the time frame, that there really wasn't enough time in this project to adequately assess changes over a longer period of time. Or it could be that so many factors contribute to some of these errors that increased management skills is only one of those factors. To be honest, we're not really sure. We were pleased that managers qualitatively reported it, but we can't honestly say at all that we can quantitatively support that outcome. Another manager, also, several other managers, in fact, this one said, I think with our falls, we had a very high quantity of falls, about 6 a month. But once we started speaking about falls frequently at our huddles that they had implemented, I got some nurses involved in our falls committee to bring in that awareness and that education back to the staff. We've drastically decreased our fall rates by bringing just education and awareness and talking about it at our huddles, rewarding team members that were doing a great job. And while that may have been true on some units, across units, again, we did not quantitatively see that. Leading for safety, a lot of managers talked about this. One so nicely put it when she said, overall, I think that has improved patient safety on our floor. And she's referring to her management development training. And she goes on to say, I think that leadership sets a tone on the floor. Hopefully it's because of some of the things I learned from this course. Morally and ethically, I set a standard because this is the way I would do things, and hopefully they are now following that. And lastly, a lot of managers talked about learning the difference between managing and leading. One nurse manager so nicely stated, I think it was an eye-opener as far as the leadership portion. And she's talking about leadership portion of the course. Going from a manager to trying to be a leader, a more effective leader, is something that I really found to hit me and I wanted to improve on. I learned a great deal about that and like conflict management and accountability. I handle things a little bit different now with the staff on accountability. Instead of doing everything, I let them do some of the problem solving, and I ask questions instead of just asking why. Why did you do that? Why didn't you do that? So that was a summary of our qualitative findings. We were pleased with those, but we also do have some interesting quantitative findings, even though our patient outcomes were not significant. So let me share some of those with you. As I mentioned before, our nurse survey had some measures embedded in it, specifically managers' team building skills. I used 6 items from the Nursing Teamwork Survey by Kalish, and I had her permission to do that. Teamwork on the unit, I used 10 items from her teamwork survey. We measured the nursing practice environment using the practice environment scale of the Nursing Work Index. Unit conflict was measured by instrument developed just for staff nurses on units. And the RNs, the nurses' medication safety practices, was an instrument that we developed in our prior INQRI study, and it was based on qualitative interviews with staff nurses. And we found in our prior study that a constellation of items were, in fact, significantly associated with fewer reported net errors per 1,000 patient days. So we used that scale in this study to measure safety practices. And what we found was very encouraging quantitatively. It supported our basic premise for nurse management development, and that is that we found all four of these items: managers' team building skills, teamwork, practice environment, and conflict on the unit to be significantly associated with nurses' medication safety practices in the expected direction. And because nurses were embedded in units and units were embedded in hospitals, we did use multi-level modeling, 3-level modeling, to estimate the impact of each of these predictors on nurses' safety practices. So, how does this happen? What are the operant mechanisms by which nurse managers' skills affect safety practices on the unit? So we did a little mediation testing with this, and we found that, as we expected and as Aiken's model predicts, that in fact nurse managers' team building skills did support a more practice environment, and it was that supportive practice environment that was the operant mechanism in enhancing nurses' medication safety practices. So there are several aspects to a supportive practice environment. A competent nurse manager is just one, but as these quantitative findings support, it's an important one and something that we do need to pay attention to in developing. And what about enhancing teamwork? And again, this mediation model was partially supported in that by nurse managers' team building skills, enhancing teamwork, and teamwork is one of the operant mechanisms that enhances nurses' safety practices in this study. So this was theoretically expected, and we are thrilled that we were able to demonstrate the importance of nurse managers' skills quantitatively. So unexpected findings, actually there were, and we uncovered this rather anecdotally. I was talking to one of the nurse managers at one of the workshops, and he said, "I'm so sorry if I look tired today. I was up all night doing staff evaluations." And I said, "Oh, gee, that's a shame. How many did you do last night?" And he said, "Last night I completed 60. I said, "Oh, my goodness, how many people report to you?" And he said, "I have 120 direct reports." We were shocked. Perhaps that's our own naivete. We did not realize that in acute care settings, frontline nurse managers can have up to 120 direct reports. So we did a quick and dirty survey of our nurse managers and asked them, "How many people directly report to you, by the way?" Something that we hadn't really considered prior to this point. And we found that our frontline nurse managers across 17 different hospitals managed somewhere between 40 and 120 direct reports, that 50% of them had greater than 50 direct reports, and that almost 20% of them had greater than 90 direct reports. And as I begin to talk to CNOs around the country, I find that this is not unusual, that due to changes in reimbursement, cost efficiencies, structural issues, etc., that the number of staff directly reporting to frontline nurse managers has seemingly skyrocketed over recent years. So I think it's important that we ask ourselves the question, how many direct reports are appropriate for a frontline nurse manager if, in fact, we want them to use these transformational leadership skills, we want them to use principles of crew resource management to engage their staff. How well can you do that if you have 120 direct reports? So building on that, directions for future research, I can tell you that we have designed a future study or a potentially future study. We have at currently 25 to 30 hospitals that are committed to participating in this study from 4 states currently, New Jersey, Colorado, Montana, and Idaho. The study is fully designed. Measures have been selected, looking at the impact of manager span of control on the care that's provided on the unit via several indicators for that, and a set of outcomes for the nurse managers, their staff, and their patients. I've talked to INQRI. We have a draft contract and cost estimates for getting those patient outcomes data from all the participating hospitals. Everything is set, except we are now currently searching for funding. So if anybody out there in our audience has any ideas for funding for something like this, please let me know, because this is something that we would really like to pursue in terms of a follow-up study. But how did we go about disseminating, and what are plans for future dissemination of the NMAP program or something like it? And I have to say, we designed this for the frontline managers themselves to be a key disseminator, and we gave them train the trainer workshops and workbooks. Quite honestly, I'm not sure how that's going. I suspect that it's variable, that some are very good at it, some are reluctant, and perhaps some haven't even tried it. But it was part of the program, and they left with the materials to do that. I do know from talking to from folks back in New Jersey that the New Jersey Organization of Nurse Executives is looking at adopting part of this program. They've contacted some of the faculty who delivered this program and are adding portions of it to their current offerings. Similar with several of the participating hospitals, that they are replicating all or part of this program themselves within their own institution. But I think that if nothing else, it has been very helpful at raising awareness of the need for frontline manager development and some of the positive benefits and outcomes of frontline manager development, and for both qualitatively and quantitatively highlighting the contributions of good, competent team-building managers to nursing care processes, and ultimately, hopefully, to those processes that are aimed at keeping patients safe. So, what can we conclude from this project? That frontline nurse managers are very important to enhancing medication safety, for example, and there are several operant mechanisms by which that happens. That frontline managers appear to benefit from manager development programs, and that frontline managers' team-building skills enhance safety by creating and sustaining a supportive nursing practice environment and by promoting teamwork. So, at this point, I'd like to open it up to questions, discussions, and any comments by Joel, who is my partner and policy expert extraordinaire.
Thanks, Linda. Well, let's take questions, and I'll chime in as we go.
Okay.
Thank
Ladies
you, Linda.
and gentlemen.
Thanks so much for a great presentation and of the results of your study. So, I wanted to ask you, can Linda or Joel, can you describe what are the key differences between crew resource management and other training programs focusing on management development that I can find out there? I mean, I see that the focus is on the focus on leadership is important on this one. But if you have any other examples, that would be great.
Exactly. Dr. Pagan, I think you hit the nail on the head. Some management development programs focus on things such as, budgets and staffing, and those things are very, very important. They're sort of the nuts and bolts of management. But many management programs don't focus on these other elements that are key in crew resource management, like transformational leadership, like conflict management, like enhancing communication, like making sure that every team member, regardless of rank, is heard and listened to and taken seriously, and also that focus on situational awareness, looking for threats to safety and actively working to reduce those threats before an incident occurs.
Thanks. I was also going to ask you, because I'm particularly interested in this in your program, and so what are your plans for the dissemination of the program in settings like you've done it in similar settings in hospitals, but also in other settings like skilled nursing facilities, assisted living, home health, and so on?
Mm-hmm. That's a really good question. And obviously I think that this is transferable to other settings. There probably is not a nursing setting where patient care is delivered or where frontline nurse manager competencies aren't important. We are happy to share the Train-a-Trainer workbook. I'm happy to connect facilities that are interested in this to the faculty who delivered this. But that type of dissemination, it takes money and takes funding, and I don't know what we can do other than help facilities make those connections. If that answers your question, I would be happy to hear from members of the audience or members of the panel in terms of ideas on that issue. That is an important question.
Thanks, Linda. So let's open it up and see any comments or other questions that participants may have.
Hi. It looks like we have a couple of questions that have come in on the web, and one of them actually does refer to this, asking if the NMAP program is available for use by others. So, Linda, I don't know what you think, but perhaps that's something that we can offer through the website or some sort of distribution. Mm-hmm. I'm not sure. Maybe that's something that we can make available. What I'll do is I'm going to put my contact information up in the chat feature. So if that's something that you're interested in, go ahead and send me an email, and we'll get you connected with Linda and Joel, and we'll facilitate that. But I also have another question that was submitted asking if you could talk a little bit, Linda and Joel, about the measure you used for teamwork.
Oh, for teamwork? Okay. The measure for teamwork was, I think it was 10 items from Beatrice Kalish's nursing teamwork survey. And that's an instrument that she has published about. It's got good reliability and validity. I contacted her, got permission to use it, got a copy of the instrument. So I would just suggest that people contact her for a copy of that instrument. Did that answer your question?
Thank you. Another one is submitted asking if you could talk a little bit about the role playing. You talked a little bit about the things that you did during the role play, but asking if there were barriers to participation there. Did people feel comfortable or uncomfortable? If you can describe that a little bit.
Sure. No, and I think it might be important to bear in mind that these were experts in their field who were delivering this content, and they were very skilled in engaging managers or engaging participants. No, there was not. People participated in the play. We hired some actors to do key roles, but the participating nurse managers also had roles. They engaged in role playing, all kinds of simulation and sort of games and learning activities to make the point. They were very much engaged. It wasn't a problem.
Great. How are you thinking about sustainability? Are there plans to bring back participants over time?
Oh, wow. Sustainability is always one of the most difficult and tricky questions. Like I said, we tried to build that in by the Train the Trainer workbook, by encouraging and training the participants to go back to their hospital and engage other nurse managers in this. We have access to the to the team, to the implementation team. We can give other facilities their name and contact information. But other anything more than that, again, there most likely would need to be some kind of a funding source or some way that would help us to do that. And I'm not sure what that is at this point for a more a greater arena of dissemination.
And if I could also just add, I think
sure.
In the rubric of continuing education requirements, there's thinking this is sort of more down the road from a policy perspective. If we could power up a larger trial and demonstrate hard numbers with safety outcomes, I think then going to boards of nursing and talking about continuing ed requirements, not exclusively for this model of training, but for nurse manager training more generally, might be something we can at least dream about down the road.
Joel, I think that's an excellent point. Part of our point in all of this was perhaps not so much this curriculum, but nurse management training in general, making that point about how important it is. So I think from a policy perspective, that's a great idea, that there could be some kind of continuing ed requirement for nurse managers, some development requirement for nurse managers through a policy initiative. That might be the ultimate way of addressing this.
Very good. I don't see any other questions that have come in on the chat feature. If you do want to ask a question, you can push *1 on your phone to be unmuted.
So Linda, it's Jose again. I thought it was interesting that the fall rates when you were looking at outcomes, they did not fall. They did not change, and I was wondering if you think that you were looking at the right outcomes.
Probably not. That's a great point, Jose. Joel, do you want to add anything to that?
And I was thinking
obviously we've thought a lot about the sort of disconnect between the quantitative and the qualitative findings, and I think our accidental finding that the reach of the large number of direct reports of the nurse managers may be so big that the impact on the nurse managers gets quite diluted when it comes to the supervisees, and that's a possibility. So they may well have experienced improvements, but it just gets diluted over such a large base of nurses practicing on the units. Also, I sort of implied this, but when we designed the study, we were limited as to the length of follow-up, and it may just take longer for the effects to show up quantitatively. Also, in terms of statistical power, perhaps the effect sizes were too small for us to detect. We didn't really power this as an efficacy trial, since it was a translational project. So if we could get the resources to do a much larger scale trial, I would bet that we would find those hard outcomes quantitatively.
Thank you.
I have two more that were submitted online. When a serious medication error occurs on a nursing unit and other disciplines are involved, for example, pharmacy or medical safety officer, HR, nursing administration, etc., how does the nurse manager use transformational strategies to address the issue?
That's an interesting question. In our prior inquiry study, and our medication safety study, what we found is that by interviewing staff nurses, that there were various ways in which they enhanced patient safety and tried to identify medication errors before they reached the patient. Not before an error occurred, but before the error reached the patient. And that seems to be nurses' key role in medication safety is, and they identified things such as, questioning why every single medication was ordered. Is this medication still appropriate? Should it have been discontinued? Should it be increased? Should it be decreased, et cetera? By having assertive, not aggressive, but assertive and clear communication with physicians about the medication orders, about asking in areas that did not have CPOE, asking doctors to rewrite orders that were written with incorrect abbreviations or that were unclear, by making sure that they knew the patient very well, that they knew all of the nuances of their status, because we know status is quite dynamic when patients are in acute care situations. Going back and making sure that what they have on their MAR, their medication administration record, can be substantiated by orders in the patient's medical record. So some steps that were above and beyond what normally the nurses would do on a particular shift. So there were several categories of things that the staff nurses identified that they did to detect a medication error and intercept it before it reached the patient. And that's what nurse managers can do. They can provide that kind of supportive environment where nurses feel comfortable doing those things, where nurses are rewarded for doing those things, where teamwork between nurses and physicians and nurses is expected and supported. So that's how I think is the role of the nurse manager in that. It's not who commits the error, it's detecting it and intercepting it before it reaches the patient. Did that answer the question?
I think so, yes. Thank you. There was another question, and you may have already said this, but the transformational leadership text that was used, what was the name of that textbook?
That is the book by Karen Kowalski. So it's the Kowalski text, and it's called Beyond Leadership.
Beyond Leadership. Great. Debbie, do we have any other questions in the audio queue?
We have no questions at this time in the audio queue.
Okay. I just got another one. Beyond Leading and Managing is the...
Oh, thank you. Okay, that's it.
Perfect. Thank you. Very good. Well, I don't see any other questions that have come in, and we are right up at the hour. So I will want to thank all of you so much for joining us. Jose, Mary, Mark, I know I speak for all of you, but I want to thank Linda and Joel, and of course Jose, and all of you for joining us today and being part of this wonderful session. This session is recorded, as we said, and will be made available on www.INQRI.org by Monday afternoon at the latest. It will be a YouTube video that you can view as many times as you'd like and forward to all of your friends and colleagues. So thank you so much for joining us today.
Thank you.
Thanks, everybody. This was terrific.
Thank you.
Thank you. Thanks, Joel.
Bye.